we are so glad to be able to propose you this wonderful lecture that is going to be made by Dr. Juancho de Quixano, that many of you probably already know for all his work in ankyloglossia. Juancho is a doctor in dental science that specialized since a long time on ankyloglossia and breastfeeding. He's working for the FroggyMouth unit in Barcelona, the first team in Spain dedicated to the breastfeeding and the ankyloglossia, but also being an active member, a lecturer at the International University of Catalonia, making his own course and being the co-director of the ankyloglossia program dedicated on pediatric patients at the ISNUT organization. So we are so glad to welcome today Dr. Juancho de Quixano. Please join me on stage for this wonderful lecture that is named Understanding the Tongue Posture from the Anatomy to the Clinical Tools. I am so glad to have you here in Paris with us, with the FroggyMouth team, with the Biotech Dental team, and we are so glad that you could come directly from Spain for this beautiful lecture. It's time for me to leave you the floor, and we see each other in an hour for the question and answer session, because at the end, do not leave us, stay for the question and answer. Please, Juancho, the floor is yours.
Thank you very much. So, everyone, welcome. First of all, I'm very, very glad to be here, and I really want to thank the FroggyMouth family for giving me this opportunity, for me coming from Spain, lecturing in France, Paris, and in English, which is not my language, but as you will see, I will try my best. What I want to do is, during the next hour, try to maybe change or expand the way in which we see tongue posture at the moment. I come from a background that I will now tell you, in which the position of the tongue and its relation with the movement is very important to us. Normally, as a dentist, that is not something that we normally take into account, but every year, more and more, we start to get worried about very important things, such as this one. Okay, so opposite of what kindly my colleague said, many of you won't know who I am, and I just want to introduce a little bit of myself. Okay, I could tell you about all the things that I've done or studied, but I think that the main aspect I can tell you about me is the fact that I am a tongue-tie geek. Whenever you start talking about tongue ties and ankyloglossia, you become almost obsessed with it. Now, the thing is that whenever you see a restriction of the tongue and the movement, the position, and start relating all of this functional part with the repercussions that you can find in the body, it becomes very complicated to look to the other side. Okay? So, I come from Barcelona, and I am lucky enough to work in a breastfeeding clinic, which may sound very different or strange to you, but in Barcelona, there's a Barcelona-based app for cell phones, which is called DACTAP, which was developed 9 years ago with the intention of helping mothers in all of the breastfeeding process, regarding the kind of feeding for the baby that they wanted to experiment. So at some point, they saw that part of the issues that they were having was regarding the tongue tie, and that maybe the surgeries should be necessary. That's why we're lucky enough to be invited to work with them. And as you can see in this marvelous artificial intelligence generated image, this is part of our team, in which we work side by side or hand by hand with pediatricians, pediatric surgeons, dentists, speech therapists, osteopaths. So what we really try is to do a full circle in all of the different aspects that a tongue may need. And you may think, wow, a tongue is such a small part of the body. But yeah, if you think about it, it's one of the only autonomous muscular parts that we have in our body at the moment. So what I will try to explain to you today is how the posture is affecting several conditions on our body, and what can we do to improve this kind of posture. Okay, so let's get started. Let's start with the basics, with a little bit of anatomy. Okay, as many of you will understand, we normally look at a frenulum in a frontal part. No, we have the two veins and the two glands. These two different structures compose what we know as the diamond, or that famous diamond that we can see probably after a frenotomy or frenectomy. This is important in our front part. Why? Because we need to know our emergency margins in terms of a surgery, but it is very important to know that the frenulum, or the lingual frenulum, is a 3D structure. It's some sort of camping tent. So what we're looking at is mainly this front part, which is what we call actually the frenulum, which is basically made of collagen type 1 and type 3, but that is just the external part. That is not the only part who is causing the tension underneath the tongue, okay? This is what we call the tent, or the camping tent, and it's important to know that not only the front part, but the back part of this frenulum can be causing some sort of tension, okay? It is important to understand that every human being must have a frenulum underneath its tongue. Why? Because it's a mechanism to control the correct movements of the tongue in terms of back and forth in a most linear movement. The thing is that in some cases, this frenulum can be restrictive in some way. We normally speak about this kind of tongue tie as a short frenulum, but that is something that we can discuss for a while. That is not actually the truth about it. Because, as we will talk in a while, a type 3 tongue tie could be exactly as restricting in a 30-year-old or in a 2-month-old. And it's not typified how long it should be for each of those individuals. So what we're looking at is how this lingual frenulum is impacting in not only the movement of the tongue, because as we know, speech therapists or even physiosteopaths can treat these muscular joints in terms of improving this movement, but also in the position of this tongue, okay? So there are, as we were saying right before, Nikki Mills has several articles which are very, very, very interesting, and furthermore, her doctoral thesis tells us a lot about the anatomy of this lingual frenulum, okay? So one of the main things that we discover is the fact that we have an external part, which is the one that we see, and we have a mucosal fascia that covers all of the back part of this frenulum, giving it its 3D structure or position, and that is in an intimate contact with the muscle, but that is not joined to the muscle in newborns. This join, or this sort of blending between the frenulum and the muscle, will come when this tongue starts to gain its muscular strength with what? While we start to speak, when we start to swallow, when we start to eat solid food. It will be months or years afterwards when this tongue will start to gain muscular tone, and then this frenulum, or the most posterior part of this frenulum, will start to blend with this muscle, okay? As we can see in this situation, okay? We can see the frenulum, which is what we normally call the frenulum, but we can see this sort of shade that is the blending between the most mucosal part and the most muscular part that is already belonging to the tongue. It's important that when we are born, this part of mucosa belonging to the frenulum is not in contact with the muscular part yet. There's some sort of space between them. There's not real space because in the body we cannot have like an air cavity of this sort, but there's like a dissection plane that you can identify between these two different layers, and I will show you in different videos, okay? So what we have been starting to see is the fact that this part is normally the one that we try to treat when we talk about tongue ties. But what about this part? This part is the one that is tensioned in a way that shouldn't be happening, or at least not how we would like this tongue to be invited to move in a certain way or another one, okay? So in terms of anatomy, in a frontal view, and obviously I'm not the expert to talk about this, but you know that the tongue is composed by several different muscles. So we can talk about them that normally in a frontal view, they are layered in this type of structure, but it will be the genioglossus, the one that is directly attached or pulled by the tongue tie, okay? So in this case, we normally tend to look about this function because what we've learned from physiotherapists or osteopaths is that they are so used to treating consequences of certain problems that they normally work around or with the muscles surrounded the exact muscle which is implied, and then they normally gain a lot or even a full restoration of the function without dealing exactly with the muscle involved. So we people who normally treat or deal with tongue ties, we're quite obsessed with this muscle. This muscle has a particularity that because all of them are joined, like in the most central part of the tongue, like the line which is right in the middle that separates the two halves of the tongue, we see that one of the problems is that when the genioglossus is pulled, the superior longitudinal is incapable of contracting in conjunction with the rest of the muscles, and one of the movements that is totally incapable of doing is this contraction of the tongue in order not only to raise its position to the palate, but also it's preventing the tongue from doing this contraction movement. So if we generate a tension in this lower part, it will be seen as well in this upper part, okay? This union between the muscles is normally seen more clearly half through the tongue or in the posterior part. Once the front part or the tip of the tongue is a little bit more free, in a sense, this is where this kind of position can be a little bit muddled up, okay? So I'm going to try and show you what are the tips to try and see when is the tongue resting really in the palate, or is it just the front part of this tongue, the one that is doing most part of the job, okay? So this image is not related to this article by Dr. Fellus, but it's something very important for me because this is the first article I read in which someone was talking about the posterior part of the tongue. You know, if we divide the tongue in 3/3, we have the tip, we have the middle third, and we have the posterior third. In this case, and this is the moment where the people from FroggyMouth started to catch my attention, because I was talking to them, I was listening to their explanation, I was like, okay, but now I will talk about tongue ties, and you will have nothing to tell me about. And it's before I could say anything, they said, okay, but this will not work with posterior ties, which are the ones responsible for the traction of the most posterior part of the tongue. And I was like, ooh, now this is getting interesting. And why is this important? Because if you see the shape of the genioglossus muscle goes from the alveolar ridge right directed to this zone, which is the postdam area. This line or imaginary line is the line that separates the hard palate and the soft palate. This is very important because it will be this line the main responsible for the negative pressure. Negative pressure or vacuum is the effect that does the tongue against the palate, which why it gets stuck. It's the same that when you're talking about dentures for people without teeth, if the denture doesn't get to that line, if it doesn't reach that limit, that denture will probably fall off, because that transition is the one that would hold this negative pressure. It is very important because if we do a correct stimulus of that zone, we will be able to do many things. The main thing that we will do is try to allow nature to do its thing. If the genioglossus muscle is supposed to lay in that line, it is obvious that we need to let the muscle rest in its place. If that's not happening, we need to reevaluate what's going on. Is it a tongue tie? Is it something different? I specialize in tongue ties, so that's my first approach, but it can be many others, okay? In this case, if we do a correct stimulus of that zone, what we're doing is allowing the body to combine the adequate movements to develop the normal functions. For example, if I want to swallow or if I want to talk, I have to do a correct stimulus in that zone so that the soft part of the palate can move accordingly to allow the food to go inside the mouth, but at the same time close part of this air that's coming in and out in order so that we don't choke. If we want to speak, we need to allow this part to move correctly so that the air is in the exact amount, and then we can express the sounds as they should be done. Furthermore, if I do the negative pressures as we were talking about, I will allow naturally to the tongue to be stuck right on the palate, and if I do that, I will start, or I will allow the fact that the musculoskeletal structures in head and neck start to develop as they should. If I do a correct pressure in the palate, this palate will start to expand. If this tongue is pressed towards the palate all day long, I will allow the mandible to do an anterior rotation and do a correct, not expansion, but to obtain like a correct position in terms of the relation with the upper jaw. So, that said, it is important to try and understand where this line between the hard and soft palate is. Because in an adult, it may be quite easy to find out. Why? Because we not only have teeth, but we also have a much more developed upper jaw. In a baby, this can get a little bit harder. And why do we talk about babies? Because babies is the first stage, and one of the ideal time to treat these sort of problems, because this baby hasn't developed yet, and we can directly act on this development process, okay? What is a tongue tie? Because I've been talking about tongue ties, and maybe some of you don't really know exactly what we're talking about. A tongue tie is a congenital malformation that is caused due to the absence of apoptosis. What's that? You know that embryologically, when our head is forming, it goes from back to front, and at some point, it starts to reabsorb the tissues. This is because of the cellular death, okay? If these cells die in the correct way, my tissues will reabsorb in the correct way. In the 8th week of embryonic development, this normal natural apoptosis finds a stop. Why? There are many reasons that we can talk in another moment, but this, what's causing is the fact that the lingual frenulum does not position in the exact place, and therefore, if this frenulum is not in the correct place, it will not allow neither the correct movement nor the correct position of this tongue, okay? This which is a syndactyly that you maybe know about it or have seen at some point this kind of images, is exactly the same that we have underneath our tongue. When we're talking about tongue ties, we're talking about the buccopharyngeal membrane. When we talk about syndactyly, it's the membrane between the fingers. What's our main problem? That when we see this, everyone will start getting worried because my kid cannot go around with two fingers tied together. But if we think about it functionally, this kid will do everything. He will throw a ball, he will send a text message, he will probably play the guitar, maybe the trumpet. It will be a little harder, but he will do probably 99% an ordinary life. But when we're talking about a tongue tie, which is a condition that can affect us vital functions such as breathing, swallowing, development, but it is not seen, or maybe the way we speak is the correct one, we are evaluating statics over real function. So this is where we have to start to rethink and change, okay? In a classical classification, probably who know about this, about Corellos and Hasselbacher, they are the ones who mainly try to classify this sort of condition. They normally talked about 4 types of ankyloglossia or tongue tie types, okay? Mainly divided into 2 anterior and 2 posterior. Number 1 and number 2, consider the more anterior ones. Number 3 and number 4, consider the posterior ones. However, historically, number 4 is the forgotten one. Why? Because we always thought about this clinical or physical evaluation of the frenulum. And number 4 is a frenulum that is hidden in the mucosal plane. What does that mean? That you don't see it unless you traction this tongue towards the palate. In that case, you will maybe see some sort of ischemic band that will be the sign that maybe lets you think about the possible appearance of a tongue tie. What's important to think is that if you don't see a structure, which is the frenulum, that should be seen because every human has it, this makes us think that this frenulum is not in its place. If it's not in its place, then probably it will not allow the correct function or posture, okay? To define it pretty easily, number 1 is a frenulum which is attached to the tip of the tongue, and in its lower part, it's attached to the alveolar ridge. Number 2 is the same, but it's just not attached to the tip anymore. So it leaves us a slight movement of the tip of the tongue. Number 3 and number 4 are posterior ties, and the main difference is that the lower part of this frenulum is tied to the glands, okay? So whenever we have a little bit of a doubt between 1 and 2, the tip of the tongue will be the main thing to look at. But when we doubt about 2 or 3, because they can look exactly the same, we have to look where is it inserting in the floor of the mouth. Is it in the alveolar ridge? Then it will be a number 2. Is it in the glands? Then it will be a number 3, okay? The thing is that some years ago, we started seeing that there were 2 tongue ties that didn't exactly match what we had been told about this kind of description. Actually, number 1 didn't match it as well, but number 1 is a strange one, which I will tell you about later. Number 4, we started to see that it was far more problematic than what we had been told until the moment. We treat patients of all the ages, and we see the consequences that they give. We have a very geeky study about consequences throughout the years and throughout the different stages of life. And number 4 kept on appearing. But number 2 gave sometimes similar symptoms. Why? Because if you start reading again articles like Nikki Mill's articles, or you do a certain amount of surgeries, you see that there's a front part, but like we have been talking, there's a posterior part. This posterior part, the floor of the tent, if you want to call it, it's obviously causing some sort of tension because it's not a two-dimension structure. It's a three-dimension structure, okay? So what we wanted to do in this case was try to do a new classification based basically on function, okay? This is when things can get a little bit weird, but I will try to explain myself as much as I can, okay? Because I need to accelerate a little bit. Number one, classically, we call it an anterior tie, and it's a tie that we've only seen once or twice in 15 years of practice. It's a very atypical tie in terms of anatomy because it's attached to the tip of the tongue, but the back part of the tongue can completely adopt this position of dome in order to adapt perfectly to the palate. In this case, in terms of breastfeeding, sometimes the movement that should be done by the furthest part of the tongue is correct because the only part that's tight is the front part, okay? The rest of them, we say that all of them have a posterior component. Why? 3 and 4, in our case posterior and mucosal, obviously have a posterior component. Mucosal, it's the old type 4 because it is encapsulated inside the mucosa. Okay, that's why we don't see it until we traction this mucosa. The posterior tie would be similar to the type 3, that small tie that you can see like in the furthest part of the tongue, but that you can actually see it. And the combined one, this is the one where it gets tricky. It's that kind of tongue tie that you cannot really say if it's a 1, a 2, or a 3, but it has a special characteristic. It's the fact that it has 2 points of tension. The one that we see, the white part, and the three-dimensional part of the frenulum is also generating a traction, okay? This is very important because in terms of surgery, when we try to treat number 3 and 4, or what we call posterior and mucosal, in many cases, in the same surgery, you break that posterior layer and then you get good results. Sometimes on purpose, sometimes accidentally, but we end up doing it. When we talk about combine, in many cases, we just intervene that white part, that front part, and we forget about the posterior part. And then several months after or several years after, the results we were expecting are not exactly fulfilled. Why? Because we know today that there is a part that anatomically we are forgetting about, okay? What are the consequences that today, at least today, have been studied and that we can argue with articles on our hands? Speech, swallowing, lactation, breathing, facial or musculoskeletal development, and posture, okay? This is mainly thank you to the fact that many different disciplines have joined together to say, hey, on my side, this is what I see with a kid, in a kid with a tongue tie. And the other say, this then gives me an answer of what I'm seeing in the mouth while I treat several caries or whatever. In this case, I just want to focus mainly on 2, which are the ones that are directly or physiologically impacted by the tongue position, okay? The rest of them are maybe more impacted with the tongue movement itself. Those are swallowing and breathing, okay? As we said, if we don't allow this tongue to brush the zone of the Potsdam area, we will not be able to stimulate this soft palate, and therefore this kind of procedures or movements will not take place as we would like them to take place, okay? So, very important, where is your tongue resting? okay? Normally, at least from dentistry in my country, what they normally tell us is that the tip of the tongue should rest in the palate, right above our teeth, no? In that part that we can see a little bumpy. But really, the tip of our tongue should be a little lower, maybe in the transition between the teeth and the gingiva. Why? Because if we do that, we will allow space for the rest of the tongue to create this dome shape and then rest in the palate, okay? This is what we call a vacuum position. The fact that you can do with your tongue like this and keep it in your mouth, okay? This tongue position is very important to identify because it's not the same to have the whole body of your tongue resting on your palate than having it like this. I can use the sides of my tongue, I can use what we call the wings, to do some sort of fake surrounding of the palate, but the central part of the tongue is not doing that contraction movement that we've talked about before. Therefore, at some point, maybe at 2 a.m. in the morning, when our sleeping phase is the most deep that we can have, this tongue will not have the main tool, which is the negative pressure, to maintain its position in the palate. At some point, it will fall down. This happens a lot when we evaluate tongues with obviously a conscient patient when he's waking up. Just try to put your tongue in the palate, and it looks nice. But why is he or she not capable to maintain this position throughout the night? And what is happening so that there are consequences that we can see in our body that we shouldn't see if this tongue was perfectly positioned as we thought before? So this is what we have to evaluate. When we talk about babies, as I told you, it's a very good moment to see this. We can see that this is how the tongue should lay in our palate. But it really isn't. There is a patient that we had to treat for a tongue tie, but his speech therapist was against it because she said that the tongue position was ideal. The thing is that after looking at this patient, we saw certain things in terms of breathing, of lower jaw development, of palatal expansion that didn't add up if this tongue was really positioned in its place. So we started investigating and we saw that this is the real tongue position. If you see the picture on the left, the tongue looks inclined, sort of. But if you look at the right one, the tongue is totally flat. How do we know that? Because this posterior part can't be seen. The tip and the posterior part are in the same exact position, okay? If this baby had teeth, as you will see afterwards, you will see how not only it has a proper elevation of the tongue, but it also has a proper contraction of the same, okay? How can we test this? Pretty easy. When a baby is asleep or in the arms of his mom, totally relaxed, we can do this simple exercise. We can push the jaw and see where the tongue is resting, okay? As you can see, this tongue is totally flat. And I know that many speech therapists or physios will now say, yeah, but he's losing this capability of vacuum. Obviously, I weigh 100 kilograms. This baby is very small. He will not win me in terms of strength, but there is a very important thing that you can see. The fact that whenever this tongue loses its vacuum, you can see that it goes down in a dome shape. If there was a tongue tie, we would see how this tongue does the opposite shape. It does like this sort of cup shape that we are so used to see when we're talking about tongue ties, okay? This is something that we can see inside the oral cavity. How can we see it? If this is our postdam limit, the line that separates hard palate and soft palate, can you see these two ischemic zones? these are exactly the position of the tongue. And this is causing, and maybe you can relate it to patients you have now, to a forwarded stimulus. That baby that when you try to introduce a bottle or a finger in the exploration of the suction, its tendency to nausal reflexes is very, very high. Why? Because the stimulus is forwarded. Why? Because the back part of the tongue is not laying right in the line that we would like. And it may seem very, very little, but it's that little. 2 millimeters, 3 millimeters before this line will cause this loss of negative pressure and will cause, obviously, a reaction of the malfunction of this tongue, okay? This is the ideal position in an adult. And many of you would say, yeah, but what's this? This is a tongue tie generating a traction from the tongue. No, it's not. This is the normal muscle of the tongue. This is a grown-up who has been speaking for many years, eating solid food for many years, doing new movements rather than the linear movements of breastfeeding. So that's why she's been doing tongue CrossFit or tongue weightlifting. But as you can see, this tongue is capable of contracting and fit perfectly in the dental arch regarding its shape, because now she's doing orthodontics to correct teeth position, but not before. And as you can see, the posterior part is in the same plane or the same dimension as we can see the front part or the tip of the tongue, okay? It's important to know how do we swallow. Probably I'm not the best one to tell you about it, but there are things that we can see, okay? And it's understanding that the normal direction of the lingual muscles is towards the postdam area. If this tongue has the tendency of going out the mouth instead of inside, maybe this extrusive movement should be a sign of, hey, something's not going right, maybe underneath the tongue, maybe in terms of muscular development, whatever. But that kid that's always with the tongue outside, he's very funny, yeah, but why it's always outside whenever it's not that playing or exploratory moment? What's going on? Why is he or she not capable of doing this contrary or opposite movement, okay? Here is a video of an ultrasound, okay, that is intending to show the correct movement of the tongue while breastfeeding. Why do we show this, okay? Because here, Laurie Jacobs, what tried is to show one of the most simple and linear movements that this tongue can do. So, being this the nipple, and all this is the palate, you can see that the tongue does a gentle stimulation of the nipple underneath in order to stimulate the outcoming of the milk, but it's the rest of the tongue which does this sort of wave movement, okay? When we talk about adults, this wave movement is more of a dome movement instead of so quickly or so wavy. In a baby, because it only takes liquids, it has to be much more wavy in order to create this vacuum and then do the correct swallowing, okay? This is a video done by a beatbox artist in Germany. Actually, we got this from the RTL, the German television. And as you can see, in a situation in which the air has to be modulated in such a complicated way, just pay attention that at any given movement of the tip of the tongue, there is a reciprocating movement of the back part of the tongue, which casually is stimulating the movement of this soft part of the palate. Furthermore, as you can see, this tongue never leaves the confinement of the lips, not for breathing, not for speaking, not for swallowing. So whenever we try to evaluate the position of this tongue by sticking our tongue out, that's maybe something to reevaluate, because that's not a vital function for the tongue, okay? So in terms of swallowing, as I said before, what we want to do is basically a sort of rounded pattern, okay? Like a sort of dome shape, but whenever we have an alteration in this swallowing pattern, what we do is some sort of step pattern, normally done in 2 different steps or more, which I will show you in different videos, okay? See how this baby is right before surgery, and the other one 2 weeks post-surgery in terms of tongue tie, okay? The first baby, as you can see, it does a masticatory pattern, okay? It's using the whole of the muscles in the mouth, chin, all of the accessory muscles that go from our skull to our jaw, and obviously the muscles surrounding our lips. See the difference with this baby, in which this part is much more still, and the main movement is from the floor of the mouth. In this case, this is the way that we can see the movement of the tongue. This wavy movement, okay, in which the lips only stabilize the finger or the nipple, in this case the finger, and is the tongue the one responsible for the correct movement, rather than the compensation in terms of muscle memory, okay? In an adult, we can see the same. We can see how a patient with ankyloglossia does a 2-step swallowing. Can you see it? With the light, you see the first one, 1 and 2. In this case, what's happening is the fact that he tries to swallow with the tongue, but because the back part of the tongue, the posterior part of the tongue, is not useful or is not functional as it should, he's trying to do a muscular swallowing with the tracheal part. This can relate to all those friends that maybe when you're having dinner, they're constantly doing Why? Because they're trying to swallow in 2 steps in a totally unconscious way, because they have to swallow at some point. But as you can see, underneath the floor of the mouth, we can see that this movement is in 2 steps and not linear at all. I will show you an even bigger case. In this case, this is the movement that we want to see, okay? As you can see, this goes back and forth in this dome-ish parabolar shape, okay? You can see how it goes down and up again. This is different from a case I will show you now, which is pre-froggy and after froggy. But give me some minutes before, okay? So, in terms of surgical approach, okay, remember that the front part of the frenulum, it's easy to see. But what do we do with the 3-dimensional part, with the floor of this tent? Okay, I will show you now 2 surgeries or images of surgeries that can be a little impacting if you're not used to them. Okay, but I will try to explain them to you. Okay, this is the main difference between frenotomy and frenectomy. For many countries, there is no real difference, but at least in Spain, it's something that we're now trying to work on a lot. A frenotomy is basically a cut. Otomy means cut. Frenectomy, ectomy, means eliminating the tissue, but it means eliminating the tissue or remodeling it. For example, when we do frenotomies with laser, that is actually a frenectomy, because while you cut with the laser, you are tearing apart this tissue and you are repositioning this tissue. So with laser, we do frenectomies, not frenotomies, in the strict sense of the definition of these words, okay? If I do a frenotomy, which is a cut, what will happen is that I will cut very easily this front part of the frenulum, but what do I do with this one? If we said that the 3-dimensional part of the frenulum is very close to the tongue, it would be very difficult to cut it without cutting the muscle, therefore bleeding, therefore possible pain. What do we do with that? We maybe need to reevaluate our technique. How do we do that? We try to do a frenectomy, frenuloplasty, or a technique in the shape of a crater, okay? Why is that important? Because the external part of the frenulum and the internal part of the frenulum will be probably as separated from one another as they should be. But as well, the fact that we're tearing apart this tissue will make the borders of this wound like a puzzle that don't fit. So it will be much more complicated for us, for the tissue to go back to its original place. Therefore, success of our surgery, but as well, it will be easier for us to eliminate with scissor or with a finger that posterior part of the tissue. Just in case I didn't explain myself well, let me show you through a video, okay? See how we do a mini incision of about 1.5 millimeters, and then with our scissors, we try to dissect this tissue, okay? According to Nikki Mills, in this case, we wouldn't be working anywhere near anything problematic, such as veins, nerves, or whatever. But as you can see here, there's a white part that is causing tension. Once we've done our cut and once we've removed our tissue, we need to try to erase it with a gauze, with a finger. Why? Because it's so in an intimate contact with the muscle that if we try to cut as much as we can, we would find ourselves probably in a problem. If this doesn't happen with a simple gauze, maybe you will need to cut one of the most posterior ties that you will find. That's something not really typical, but it can happen. If we try to standardize a technique which takes care of this tissue and understands the limitations that the structure give us, we can try to tear off this tissue until it ends in the veins and the glands, which is the biggest diamond we can get, which will allow us a correct healing process during 21 days, but it will never go further than that because veins and glands are designed to not break easily because they are covered with a muscle recoverment, okay? And that cannot be broken that easily with a finger. It has to be done with something that cuts, okay? As you can see, without almost any bleeding, we have eliminated the 3D components of this frenulum. The same we can see in grown-ups. How do we see that? This is two different cases in which you can see that here we start to see the first muscular fascia. We have erased the last mucosal fascia. That will be this one, in this case. As you can see, here we don't have any more of this mucosal fascia, and we don't have anything in our central line, which is where the tongue tie would be, that is causing us any sort of traction. What we see here is the mucosal fascia redirecting to its original place, okay? So, this part is the one that we try to eliminate with our finger, or if you're wearing loops or a microscope, then you can maybe do it with a more accurate technique, but it's not necessary because it's so soft that it will erase easily, okay? So, can we restore the tongue posture and movement? What's going on here, see that this is like a 3 or 4 step swallowing technique. You see that? And I'm gonna get into trouble because this is my wife, okay? And she didn't want me to show this video, but look at this, how she's forcing all of these suprahyoid muscles instead of using the tongue. She's using her lips and she's using her neck to do this swallowing. I said, just let me try something and see if we're in the right. Immediately with a froggy mouth placed, look at the difference. Lips are not moving anymore. The hyoid is practically stabilized, and we are trying somehow to generate a movement, an autonomous movement of the tongue. As you can imagine, this will not be forever just by trying it once, but this is telling you that this device is allowing the passivity of the muscles that should not be involved and allowing the ones involved do their part. Always when that's the cause, okay? So, how does the FroggyMouth work? Obviously, I have to talk to you about this because it's very important for us. As Dr. Felus taught us, we are trying to reorganize synaptical pathways, okay? If we had been doing everything in one certain way, we need to change this and do it in a different one, okay? How? We will do it thanks to an emotional shock. And what does that mean? Pretty easy. The way you use FroggyMouth, you must use it for around 15 minutes every single day with an special condition. You have to be seated in a right position, a correct one, and looking probably at the TV. Why? Because when you're looking at the TV, the kind of stimuli that you're getting makes you forget about the process or biological processes that would be done involuntarily, such as breathing and such as swallowing. In that case, at some point, your mouth will be full with saliva, and you will need to swallow. But you won't think about it because you will be watching television. How will you swallow? The only way that you can swallow. And how's that? I will show you now. But you can swallow two different ways. You can swallow either by creating a vacuum closing your lips or with your tongue, which is the ideal one. People who can do it with their tongue do it with their lips. Froggy prevents you from closing your lips. So you have to find yes or yes, the only other way, which is the correct one, which is by using your tongue, okay? If you allow me, I will show you how I normally try to use Froggy, okay? I normally try to do 3 phases. The first phase is using Froggy for 6 weeks. 6 weeks, 15 minutes a day, while watching television. 15 minutes, that is enough. In 15 minutes, you will create a new necessity in terms of swallowing, but I need some weeks to establish this new movement. Why 6 weeks? I will explain it later. Second phase, I do a 6-week resting period, okay? 6 weeks in, everything should be working as I would like to, and I will need 6 weeks without this rehab to make sure that this is working. And because I am very picky, normally after these 6 weeks, 12 in total, 3 months, which is not a coincidence, I normally do a 3-week refreshing. Why? Because I'm pretty sure that once these muscles find new pathways, they don't get 100% of this solution. They maybe achieve 90, which is good enough, but no, I want a 10. So I will need to go a little bit further, okay? What I do is, the first follow-up, 3 months post-treatment. Second follow-up, 6 months post-treatment. Third follow-up, 1 year. Why do I do this? This has a reason. It's what we normally call the rules of the 3 in our biological procedures. If you think about it, when you when you do a tongue tie surgery, it takes 3 weeks to heal. When you pull out the tooth, it takes 3 weeks to heal, 3 months to create bone, and 6 months to establish all of these new procedures. That's why we do the same. First follow-up, 3 months. This is when the deep tissue remodeling comes in. Second follow-up, 6 months. Why? Because tissue muscles stabilize at around 6 months. It can be 9, it can be 12, but mostly at 6 months is what we described. And the third follow-up is a year afterwards. Why? Because it's 12 months, the rule of the 3, 3, 3, 3, and then I can know that this has a muscular reinforcement that is working every single day since we started this treatment, okay? So the negative pressure can be done by the lips or the tongue, and we have to choose how do we do it, okay? By using Froggy, we prevent the use of the lips, so we have to forcibly use the tongue, okay? Let me show you another case of a full rehab, okay, in which we had a patient that came from orthodontics, and they were suspecting a tongue tie. I thought that she didn't have a tongue tie, and I said, why don't we try this, that I think that we need to reestablish the function of the third or posterior part of the tongue. See how she tried to do a negative pressure in the palate, but the sides of the tongue were falling apart to underneath the molars, okay? See the difference? What we want to achieve is this. See the difference. She is not capable of doing this contraction. Why? Because of a tongue tie. I didn't agree with that. What do? 6 weeks of Froggy. This tongue has a lineal support and a complete form of dome or shape on the palate. And what I normally do is check if this contraction is correct, which at the moment is okay, but I want to check 3 months after all this treatment, in which I can see that the tension has even improved and that this slight lack of tension in these lateral muscles has totally recovered because of the function that we were established, okay? So, one thing that we're doing now is, and with this I'm about to finish, just give me 3 more minutes, is trying to prove if this is correct. What are we doing? Trying with ultrasounds to see if we can restore this posterior part of the tongue, and we are achieving it. This is the palate. This is the posterior part of the tongue, and see how we swallow and we close this space. We are achieving it. Can we always see it through an ultrasound in this position? No, it's complicated. It's easier in adults than in babies because of the position of the structures. But what we can see in kids, not babies, 3 years old and stuff, but mainly babies as well, is the fact that if we see it in a frontal part, we can see the symmetry of this tongue. See how both parts of the tongue are working conjoined to lay on this palate. We don't have a tension of one muscle or the other because we are forcing the natural movement of this muscle, okay? See how this is pre-surgery, and you can see better or worse the symmetry, but you can see that the hyoid is moving like crazy. This is telling you that we are forcing these muscles over the normal movement of the tongue. See how right after surgery, surgery and rehab, we can see that the movement is much quicker, much more wavy, but see how the hyoid doesn't move from its place. This is what it should be doing, the stabilization of these suprahyoid muscles, okay? Therefore, and I'm about to finish, what can we use Froggy for? You always have to use it if you know how to use it and for what to use it. But if we use it to gain the exact position of this tongue, therefore make it easier for the movement, the correct movement to happen, it will surely impact in all of these things, as we've been saying, in speech, swallowing, breathing, facial development, posture. You see that I've erased lactation because normally no, Froggy must be used in older kids. I will tell you which ages, okay? Limitations that I see in my daily practice. Tongue ties. If there is a tongue tie, if there's a mechanical or anatomical restriction, there is nothing we can do except the surgery in this case. Non-functional causes. Sometimes it's not a functional cause. Sometimes it's because of a certain syndrome or a certain anomaly in development of the jaw or whatever. In that case, there's nothing we can do because it's not a problem of the tongue function itself. The age. We normally see that kids under 3, 4, they still have not achieved certain movements, patterns, or challenges that should be achieved by certain age. So we cannot expect to rearrange the tongue and achieve those challenges because maybe they don't need to speak how we would like them to speak yet. Maybe they don't need to swallow how it should swallow yet. No, what we call atypical swallowing or dysfunctional swallowing. Well, maybe we're still transitioning to that. So maybe we need to give them a couple of years before, and always with the appropriate training, okay? That's why from Froggy they give the training necessary to use this sort of devices that, although they are passive devices, they need to be known how to be used. This is a case, a strange case, which is a girl without a tongue. This is ankyloglossia. She has no tongue. So obviously, in this case, a Froggy wouldn't work because her problem is not a problem of function of the tongue. It's the fact that she doesn't have a tongue, therefore there is no function, okay? Final tips. Understand the true position of the tongue, okay, in its complete shape. Consider the posterior part of the tongue as much or even more than the tip, okay? We see that they have to combine themselves. Ensure a functional rehabilitation which is stable in time. That's where Froggy got me, because it lasts. I've seen a lot of devices that the rule of the 3 months, 6 months, 9 months, or 12 months, the effect disappears. And always, always, always work side by side with speech therapists or whichever specialist that is in charge of tongue functions in your country or in your team or whatever. This is a very useful tool that, used in conjoinment with other professionals, can be marvelous, okay? That said, thank you very much. This is my kid, no tongue ties, but a functional rehabilitation with FroggyMouth. And now he's angry because he cannot watch any more cartoons because the treatment with FroggyMouth has finished. So thank you so much for your time. Thank you for holding through the technical, from the technical difficulties. And I think we're about to pass to the next stage and start with the question and answers. Okay, be with you in a minute.
Thank you, especially you, Juancho, for this absolutely wonderful lecture about this patient that you were showing us while you were using FroggyMouth on it. People were asking you if you were using palatal expansion, and if yes, what kind of palatal expansion did you?
Good question. No, actually no, because as I recall, they started palatal expansion, but her orthodontist said that it wasn't working, that it had to do with the tongue. So in an early stage, this palatal expansor, which was a Hyrax, was removed because it was caused by the tongue tie. The problem with expansion was caused by the tongue tie. So she stopped this treatment, and because she had no treatment to do, we decided on doing this one. If the question was what type of expansor it was a Hyrax. Okay, great. Thank you for that. A second question is about how do you consider the problem with the enlarged tonsils, which are the cause for the person that is asking the question of the mouth breathing and the poor tongue posture, even though it's always complicated to bring one cause. How do you consider the problem of those tonsils? This is probably my favorite question. In Spain, we have a saying, it is, which came before, the hen or the egg? Which came before? Of course. In this case, let's think about it. Was it the tonsils or was it the tongue? No babies are born with hypertrophic tonsils, but if we have a low posture of the tongue, we'll breathe through our mouth. Our nose is designed to protect with the hairs and with the structures that will heat the air and stuff. They will make sure that this air is filtered and it's healthy for us. But if we breathe through our mouth, what will happen is that the tonsils, which is adenoid tissue, is a reactive tissue. If we have a constant aggression of this unfiltered air, these tonsils will become hypertrophic. So normally, it's the opposite way around. It's the tongue posture will lead to a oral breathing, which will lead to these hypertrophic tissues. Actually, there are many studies that are showing that if you do a correct tongue tie release in this case, but if you do a correct repositioning of this tongue, you start to breathe through your nose and these tonsils start to reduce. They will disappear, probably not, but they will reduce in a percentage that maybe allow you to do your ordinary functions.
I think it's very important to also
bring back all the theory and the fact that we cannot always find what's the cause of something, but that doesn't mean that we don't have to treat it. What's important is to be able to intervene for the health of our patients. A question that I liked was, when there's the tongue tie that goes right to the tip, would there still be posterior restriction?
Funny question. According to classical classifications, there's this sort of doubt. From what we've seen, this is a kind of tongue tie that is very, very, very atypical, and it's actually only holding the tip of the tongue. The rest of the tongue can do this complete movement of adapting to the palate. Therefore, you just have to think on the consequences caused only by the tip of the tongue. The rest of it, it shouldn't show one of these posterior attachments. It shouldn't, theoretically.
I love those theoretical questions, but I also really love that there is very concrete questions on your protocol, especially using the FroggyMouth. One that I love, especially thank you for asking, which is, how are you getting the motivation of your patients? I think it's a key part of the success, getting the compliance of the patients high. What are your tips to get that?
I must say that I normally have to do nothing. Why? Because, and this is good news for you, but it's such an easy device. If you say that someone has to use something for 4 hours, 5 hours during the night, then the engagement can change. But if you tell them that it's only for 15 minutes while you watch TV, almost everyone watches 15 minutes of TV a day. It's pretty easy. It's not hurtful. It's not complicated to use. It's not forcing anything. So for them, it's something that can be done pretty easily and that you can see a result pretty early. And that's what people want. When you do some sort of therapy, if you want to walk and you cannot walk for 3 months, you start to get frustrated. But if you start to see certain things, either you as a patient or the parents of that patient, it's very easy to engage them. So that's something we don't have to work.
I agree with you about the easy part to get the compliance, but I see also that you are treating a wide range of patients. Some of them are very young, younger than we could imagine, and some of them can also be adults. How are you explaining to the different kind of patients what is the point of doing that? Because even though, as you said, the compliance will not be the toughest part to get, the very important part is also to be able to explain them why something that is looking like meaningless, like tongue posture, swallowing pattern, why is it important for them?
We live in a society nowadays that people want the less impact in their body, but the biggest result. No? So many of these patients come with certain symptoms that can be I wouldn't say resolved, but you can see improvements in early stages. In adults, we normally use it for those adults who come from another professional and have been told that they need a surgery, and that's the only way to give a solution. No? You see that, you tell them that maybe the surgery is not a solution because it isn't, not because we don't want it to be. And then you tell them that they can change this whole surgical process for how Dr. Fredo said, an anoetic or a passive treatment. For them, it's easy to understand. In terms of kids, it's easier than that. You must watch cartoons forcibly every day. Vale, perfect, that's it. That's it. No more to say.
So much, and even more that for some parents that do not want to put their child in front of cartoons, I have to share my personal experience. I was raised by scientific documentaries, and you do not risk anything except becoming a science geek. So it's not about the screen of the television, but really what you are putting on the screen.
Yeah.
Like also with the practitioners and the device. I have to share with you a very concrete question that someone was asking. This person said, I use Froggy on a 5-year-old child who is currently missing his front incisors because of teeth change.
Yeah.
The tip of the tongue comes between the teeth to swallow, of course. This is due to the missing teeth, but what should I do? Should I wait until the teeth come back or continue with the FroggyMouth?
Very good question. If the FroggyMouth is giving the results you want, you should keep on using it. Why? Because babies don't have teeth, and you can re-educate that swallowing. This is the same. Whenever these front teeth, obviously the central incisors, erupt, everything will be easier. But the pattern that will be established precisely in the posterior part of the tongue, that's something very valuable that will be reinforced and even come back better after the central incisors will erupt. So, in my opinion, it's not harmful. Working in this before than after will always end up in a good result, in my opinion.
Of course. There is one question that I will directly take. Sorry. Two questions were on the use of FroggyMouth on patients with Down syndrome, and the person was asking, were you treating some patients already with Down syndrome and the FroggyMouth?
No, not with FroggyMouth. But yes, we do treat them about tongue and stuff. Is there more to a question, or? Yeah,
no, but me, I can already direct this person and everybody that is interested on FroggyMouth on Down syndrome to a very specific lecture, because I have to say that it is very important for us to treat every kind of patients. We had a lot to do with all the patients with different kinds of handicap. It was a big part of the FroggyMouth history. The very first patients was what we call EMC, mental capacity inabilities. Mm-hmm. And it's a big part of what we do. If I had to recommend one lecture, I will tell you to go on YouTube and type the lecture of Séverine Lambert on replay. It's available in 5 different languages. It was during the Froggy Days, a great congress that we organized. We are 25 lecturers. We are coming, like Juancho, sharing their protocol. Everybody was sharing different protocols. All the lectures are available in replay. I just do a little of advertisement for the FroggyMouth YouTube channel. What people liked about this congress is the fact that everybody was sharing their protocol. Mm-hmm. And that was also one of the questions that have been asked. People appreciated a lot you sharing your protocol, and especially this little phase of interruption before restarting. And 2 questions we are asking you to re-explain, maybe with more details or anything, this part of the protocol, and especially the part where you are restarting it.
Yeah. So what I try to do is, as I explained, try to rule by the rule of the 3, you know, in terms of weeks or months. So I normally try to do 6 weeks of initial treatment. I wait for 6 weeks and then reevaluate. In that term, because I am picky, I would normally choose 4 more weeks of treatment. So then we're talking about 12 weeks, okay? Excuse me, 16 weeks. Once we've done that, ideally, everything should be working correctly. But I normally like to reevaluate everything. I reevaluate 3 months in, which is final of treatment. I reevaluate 6 months afterwards, and then a year. Why? Because in these 3 phases, 3 months afterwards, deep tissue starts to stimulate again. 6 months afterwards, the muscular part should be almost established. And after a year, all of this muscular part, if it's been working, the machine's been working as it should, we should see certain reinforcement of the adjacent muscles. So that's more or less the timings that I like to play with. But as everything, in your practice, the best thing you can do is try. Try, because there is no exact pattern depending on the patient, depending on the situation, depending if it has an expansor or not. Just try and try to make your own protocol, which is the best thing you can do, I think.
Thank you for those precision. Linked to the protocol part, there's 2 questions that are highly linked. The first one is parent. First of all, I have no clue how you arrived at, but you are For sure, an absolutely wonderful parent if you are so much wondering about your kids' health to arrive on our dental and speech pathologist webinar like that. But this person is asking if they can directly use the FroggyMouth or must they go through a dentist or a speech therapist, which is also leading us to the question of Eliana that is very interesting. That is saying, do you usually work with the FroggyMouth first and then involve the speech therapist if it is needed? Or do you think it is always better to start with the speech therapy? How are you doing using both together?
You're asking like the ideal questions. To the parent, my recommendation is always go through a specialist, always. Someone who knows what he or she is doing. Why? Because anything you do to the body has a repercussion, normally good in this case, but you need to understand when a treatment has to be repatched or just having the adequate control. So my advice would be always to come with a specialist. In this case, Froggy can be used by many different specialties. Whoever knows how to use it is the ideal one. And the second question, as I said, I am lucky enough to work side by side with many different specialties. And I've seen that my work was at a certain level and now is probably 20 times, I would like to say better or more efficient, thanks to the protocols I have with this sort of specialist. So my answer would be, you can use Froggy if you know how to use it, but if you have the support of a certain specialist that can help you with the more myofunctional part probably, that would be ideal.
That's, I think, the best summary to always say that we are promoting transdisciplinary approach, but because of the fact that the skilled therapists are not always easy to find and they are overbooked when they are founded by many practitioners, FroggyMouth is helping to make the treatments going quicker and enable all the great therapists to treat more patients. Something that really needs to be said regarding all the myofunctional troubles is really the amount of patients with myofunctional troubles. The last study that I was reading about that, we are highlighting the fact that 85% of patients in orthodontic office were actually dysfunctional. Yeah. It's a pathology that is underdiagnosed. So everything that we can do to make the great therapists, the great practitioners able to treat as many patients as possible is something that we do to promote transdisciplinary, and FroggyMouth helps to treat more patients. That also leads me to a very clinical question that one of the attendants was asking about the lateral interdental swallows, because that's right, we often have, speaking about the underdiagnosed, people often think that bad tongue posture is a tongue thrust. And they say, okay, if there's a tongue thrust, this functions, and if there's no tongue thrust, no dysfunctions. We have to say that dysfunctional tongues are a way bigger problem than the tongue thrust problem. And this question is really highlighting that, asking if some patients have lateral interdental swallow, is it a dysfunction, and is the FroggyMouth useful for that?
Wow, very good question. As you were saying, I think today we know better, or we should know better, than just the tip of the tongue and how much can we extrude it. I think we need to understand the whole body of the mouth, and obviously posterior part and lateral parts. In this case, if you have a lingual interposition, we must first understand where it comes from. Why is it? Is it a crossbite? Is it from what we call an asymmetric ankyloglossia, which is those tongue ties that are like right in the middle of the tongue, and you cannot pull up the tip nor the back part, and then you need to go to a lateral part? Is it because of tensions in the neck? Find out the cause, treat it, but obviously one of the things that I'm liking about this device, and I don't want to sound it like marketing, but it's actually what it does, even though you don't want it to do, is work on the symmetry of the tongue. Why? Because to stimulate the postdam area, you have to use symmetry. If you only stimulate part of it, you will lose this negative pressure. So obviously, if you are trying to create a new pathway for this muscle, which is its natural pathway, but not at the moment, you will also be working on the symmetry. But in this case, in terms of symmetry, I think it's very important beforehand to understand where the symmetry comes from, and it's imperative to be treated first or hand in hand. But yes, it's very important in that case.
I totally agree with what you said and the importance of seeing that not as a one only pathology, just looking at the patient in an holistic way. There is one question that also concludes well these questions regarding the different use of speech therapy, FroggyMouth, the tongue tie. Does the tongue tie really make sense on a 3-year-old patient, on a 3-year-old toddler, and just use the FroggyMouth as training and wait until getting their compliance to make myofunctional therapy plus FroggyMouth later when the patients will be a little bit older?
So, several parts of the question. A tongue tie release can be done at any moment in the life as needed by the patient. Sometimes, depending on the type of surgery you're going to undergo, maybe you will choose to do it before or do it afterwards. This will depend on the professional. As an only therapy for rehabilitation, it can be valid if you know very well what you're doing. And maybe I'm not saying good things about my specialty, but normally speech therapists tend to understand probably better this tongue function, or even osteopaths or physiotherapists. So if the question is, can I do some sort of rehab until we get to a certain age and then do the most skeletal part? Sure. I mean, training beforehand or trying to solve things beforehand is always good. I mean, many people do therapy or physical therapy before a tongue tie release even. So in that case, I always think that leading the path to a correct result, it will be better. And maybe sometimes at the end of the surgery is like the final, no? I don't know how to say the final, like, straw. The final
exactly.
Straw. Yeah.
The cherry on the cake.
The cherry on top, yeah, that's
exactly.
it.
No, I think that's, I totally agree with what you said. What's important to say is to always take care of the patients as early, as quickly as possible, but also taking into account the situation. Sometimes the patient is a little bit too young. Sometimes we don't have a speech therapist next to us. So I think that to summarize and give a rule is every time we have the opportunity to work with a transdisciplinary team, we must catch it. But every time that we may treat as quickly, as early as possible, we may also catch this opportunity of giving the chance, the opportunity for the patients to be treated on their first years of diagnosis and as early as possible.
Our mentor always says, common sense plus knowledge. Know when to do things and have common sense, and then things will work out.
I totally agree with this philosophy. We also have some expression in French for that. And the last questions and comments that we are having for the moment on the live are mainly to thank you for this wonderful lecture. Many people are also asking what are the contact information of Juancho, that of course we are going to give to everybody at the end of the lecture. You can also ask all the questions that we're not receiving comments on the social network publication of the lecture that you can find on Instagram, the French, the official website or anything. Send us by email all your questions if you need anything. And maybe that's you can be found also on social network or contacted by
in the same contacts you will have everything,
Perfect. So we're going to tag Juancho in all the previous and future publication. You can directly contact him. I still receive a lot of thanking message, and I really want
very much to everyone.
Thank you so much from the bottom of our heart by myself, by my father, the inventor of the FroggyMouth, the whole FroggyMouth team, and the biotech team that is that we are part of now. We are really thanking you so much for coming to Paris. It was so nice for that. Us, we are seeing each other right after the summer holidays for the following lecture that is going to be announced in the upcoming days or week. We are once again making sure to always give you qualitative lectures with wonderful lecturers from all over the world. So thank you so much for staying that late with us. Thank you for attending and using the FroggyMouth. And thank you to continue to attend all the FroggyMouth webinar. Today we were more than 300 people live connected with you, almost a little bit more than 900 people that registered. So we really thank all of you from the bottom of our heart, from the whole team. Thank you so much and see you after the summer.